Let me just share my screen.
Thanks, that'll be helpful. And I'll just say next slide if that's all right.
Yeah, of course.
Thanks. Sorry about that. I don't quite know why.
No problem. Yeah, Jeremy, if you want to begin now, just again, if people have just joined, I just started recording. So if you don't want to be on camera, please turn your cameras off.
Thanks very much, Charlotte. Welcome everybody to this workshop. Thanks very much for joining. And there are some names, colleagues from around the country who I recognise. Hello, folks. Great to see you. So I'm going to get straight on with it because I've got a lot of information I'm going to impart to you. I think it's professionals who are on this this workshop. So I'm going to make some assumptions about people's background levels of knowledge and probably use some shortened terminology, but feel free to say if you need anything explaining. Next slide, please, Charlotte. So this is a national survey that's been part of a piece of work led by Ian Mail, who's a paediatrician in Sussex. And I've led a national survey around what's happening in teams and the changes and innovations. I'm just very briefly going to mention the methods, because of course you do need to know about that so you can interpret the findings. So this was a national survey that went out to paediatric and mental health based children's autism diagnostic teams across the UK. It was distributed through the summer and autumn, so overlap with the COVID period, but of course COVID wasn't the focus. We really wanted to know about what was happening in teams. We asked for a response per team. The survey request went out via national networks and also was supported through the National Institute for Health Research, clinical research networks. The scope was from receipt of referral to diagnostic formulations and not the period of intervention. So I will talk about recommendations, but I'm not going to talk about what happens after those recommendations are made. And we got that this is a final, the final responses were received in December. So this is an advanced draft of the results, not the very, very final version. Thanks, Charlotte. So just moving on to the next slide, what do we all want to achieve from autism diagnostic services? Well, we want a high quality, timely, reliable and valid diagnostic assessment, but autism or not is a key question. But I think it's crucial, and I think we would agree that families need a summary of the child's strengths and difficulties. They need to know whether the child has other neurodevelopmental conditions or coexisting conditions. They need a robust diagnostic formulation and recommendations about interventions and treatments, and they need that in a timely way with a written report afterwards that they receive as well as other professionals. So I hope we would all agree with that, and I think that's pretty much what NICE guidance says. Thanks, Charlotte. So it was 132 surveys completed in the end because 4 came in after this analysis, but I'm reporting on the 126 today. So 69 neurodisability or community paediatric teams, 44 CAMS teams, 9 integrated services. We might want to talk about those afterwards. Geographical representation was very good, particularly across England. I'm not going to present those data. And as you might expect, most of the teams were in mixed communities with 27 urban, 6 rural. Thanks, Charlotte. So only 30 teams were able to tell us about what had happened to their autism referrals between 2015 and 2019, but of those 30 were clear that their referrals had gone up by 109%, so from 144 median to 301. That then led them to autism assessments that had gone up from a median of 113 to 180, so a 69% increase in the number of assessments. Most people knew about their waiting times. So you can see these data are from 71 teams. They were very similar for paediatrics and CAMS, 10 months for paediatrics, 9 months for CAMS. So that's an average wait, meaning of course some people are, have much shorter and some people have much longer waits. The longest were 2 years. Really importantly, I think, if we think about the NICE quality standard, only a third of these teams started the diagnostic assessment within 3 months of the referral. So that's really pretty low, and I'm going to come back to NICE quality standards as we go on. Thank you, Charlotte. So this table at the top shows the number of Pediatrics and CAMS teams who always meet NICE guidance. That's the first one. Mostly meet NICE guidance, or around half of what they do meets NICE guidance. So you can see here that 45 out of 69 paediatric teams, and about the same proportion, so 2/3 of the CAMS teams, were able to meet NICE guidance half the time or more. Okay. So there's been a lot of discussion about NICE guidance in autism, and we can talk a bit about it afterwards. But clearly, many of these teams are doing really well. We have to flag that, but I think we also have to flag that a lot of teams are not meeting NICE guidance and are some way away from that. These are the main difficulties services said they had meeting NICE guidance recommendations and quality standards: increasing numbers of referrals and demand and capacity, lack of experienced clinicians, no medics, no psychology, no time to follow up, provide post-diagnostic support. Next slide, please. People frequently collected information prior to the assessment. School visits were done the least frequently, just 20% by Pediatrics, 30% by CAMS. We know the value of those, but people are saying that they don't have time to do them. So most commonly, people are taking account of reports from health and education professionals. Next, please. So I'm going to talk you through this table, and there are a number of other tables I'll talk through to make it as easy as possible for people to understand them. People really found that the pre-assessment information was really useful to them. 80 or 90% or so in Pediatrics and CAMS said it made a difference to their diagnostic assessment and it improved the quality. 2/3 thought it improved the speed. 2/3 or so thought it improved the identification of coexisting conditions, and about 3/4 said it improved overall satisfaction. So I think that is a clear message from clinicians that this pre-assessment information that they're mostly gathering through reports is useful. Next, please. So in terms of standardized history taking, people are able to do some of that, but fewer in Pediatrics and in CAMS. The ADOS, I'm going to assume you all know what that is, but it's an observational one-to-one social communication assessment with a child. Most people using it and having access to it. Worryingly for me, do all children seen have a physical examination? 3/4 of the children in Pediatrics, just 11% of the children in CAMS having a physical examination. And of course, they may or may not have seen Pediatrics before, so I think that's important. We'll come back to it. Do you undertake physical investigations with many or most? Again, Pediatrics doing many more investigations when they're indicated, CAMS doing far fewer. Next, please. In relationship to coexisting conditions. So this is a NICE quality standard. Children having a diagnostic assessment are also assessed for coexisting physical health conditions and mental health problems. So 95% of teams said sometimes or always, which is the good news. But it was always for only 70% in Pediatrics and only 57% in CAMS. And in terms of a personalised plan that was developed and integrated in partnership between the family and carers and the team, 3/4 said sometime or always, and it was only around half that was always for Pediatrics and CAMS. So I think we can see here real evidence that people are struggling to deliver these NICE quality standards. They are there for a reason, so we can come on to that further later. Even less good was the proportion of teams that were able to be offered a named key worker to coordinate the care. So on the left-hand side of the table at the bottom, you see 20% always for Pediatrics, 48% for CAMS, so better in the CAMS services across the board. But rarely or never for Pediatrics, adds up to 60% not able to provide a key worker. Next, please. I think this is a really important one if we think about that first slide about what we want. Families have a documented discussion with a member of the team about opportunities to take part in age-appropriate interventions to address the core psychosocial interventions to address core features of autism. So it's about 60 to 70% from the Pediatrics and CAMS teams who say they are able to do this, and the rest say rarely or never. Bear in mind that this is about interventions to try to support children's development moving forward. I think these numbers are less good than we would have hoped for. Next, please. So I'm going to come on to the highlighted points of these slides. So this is about the components of the multidisciplinary team and the core professionals available and the professionals available to the team in some way. Okay. So we know that the professionals on the left-hand side that NICE guidance suggests should be involved in some way are set out there. Not a surprise that most paediatric core services, that's the top yellow box, have a paediatrician in them, but only 2/3 of the psychiatry teams have a psychiatrist in them. 45% of the paediatric teams have a psychologist versus 86% of those CAMS teams. Only a quarter of the teams have access to a psychologist who's available to them outside the core team. So psychology representation remains a problem in paediatric teams. Speech and language therapy is well represented in those paediatric teams, 90%. 43% of the psychiatry-based CAMS teams, and both teams and professions having real problems with occupational therapist representation, with just 1/3 having an occupational therapist in the core team. Not a surprise that at the bottom, CAMS teams have more representation from specialist nursing. So this is important because it will move on to it'll help us think about the assessment and recommendations aspects we're going to talk about next. So just to summarize, fewer medics in the CAMS teams, fewer psychologists in the paediatric teams, fewer speech and language therapists in the mental health teams, and neither teams doing particularly well with representation of occupational therapy. Nurses, much more representation in mental health. Next, please. Again, I've put yellow boxes in because it helps us think about specific conditions on the left-hand side of the slide and whether paediatrics and CAMS are able to make assessment and diagnosis of these. So developmental delay, disordered development, intellectual disability are the first two we're going to look at. So disordered development, the paediatrician's much more confident about than the CAMS professionals. Intellectual learning disability, the CAMS professionals much more confident about making that diagnosis than the paediatric teams. The paediatric teams are much better at developmental language disorder, but worryingly for me, they have the paediatricians in there, but 1/3 of those paediatric teams said that they refer onwards for an assessment of developmental language disorder. That was 2/3 in the CAMS teams because they don't have speech and language therapists in there. And then you've got onward referrals from a lot of paediatric and CAMS teams for developmental coordination disorder, otherwise known as dyspraxia. Next, please. So in relationship to anxiety disorder, the paediatric teams can do this 2/3 of the time. The mental health teams are much better at at ADHD, anxiety disorder, depression, emotions and responses than the paediatric teams. That's good to see, but I would also flag to you on the right hand side these highlighted blocks, 15 to 20% of the CAMS teams not being able to diagnose anxiety disorder and depression. Seems a higher number than I'd expect, really. Next, please. Sleep difficulties and eating difficulties are diagnosed about 2/3 of the time by the CAMS teams and the paediatrics teams. The CAMS teams are much better at dealing with attachment disorder, risk, self-harm, suicidality. Next, please. So that then makes us think about recommendations, because you've got to identify these conditions, but you've also got to know what to recommend in relationship to them. So developmental language disorder, paediatricians much more confident than CAMS teams. Developmental coordination disorder, paediatricians much more confident than CAMS teams. So there's we're seeing some particular gaps here, I suppose, in the CAMS teams in relationship to those 2 points. Next. And then we're seeing gaps here in paediatrics because, surprise, surprise, the paediatricians are less good than the psychiatrists to recommend, or psychiatry teams are recommending aspects such as anxiety, depression, emotions, and responding appropriately. So those numbers are quite low there for paediatrics, I think. Anxiety disorder recommendations, 26%, 14% for depression, 50% for emotions and responding. Next, please. Okay, final lot of these, and we'll move on to a different topic. Both sets of teams, about 3/4 are able to make recommendations for sleep and eating and drinking difficulties. Low numbers around attachment and suicidality in paediatrics. 3/4 of the psychiatry teams able to do that. I'm going to use the term only 3/4 of those teams because I think I would have expected that number to be higher. Next, please, Charlotte. Thanks. We asked people about complexity. Do you think there is greater complexity associated with the young people who require assessment compared with 5 years ago? 86% said yes. Because of that link to complexity is where they need second opinions. 60% refer on to a second opinion service where needed, which means another 40% don't have access to do that or aren't able to do so. So what do they do if they can't answer the questions that being raised and then need a second opinion? They don't have somewhere to go to. Next, please. So changes in the last 5 years. Most people said that their funding had remained constant. 36 out of 120 or so said it had increased, and a decrease in 16, which is a real worry. In terms of making changes to meet the challenges, people said they'd made changes in relationship to increased numbers of referrals, more people coming through the pathway, having enough time to complete the assessment. 50% said long-term vacancies were a problem for them in paediatrics. And what about difficulties with the right MDT expertise? 71% of people thinking they had difficulties with getting the right MDT expertise to undertake the assessments. Only a third thought it was becoming more difficult to identify whether or not people did or didn't have an autism diagnosis. Next, please. So, to summarise, we've got increased numbers of referrals and assessments, increased complexity, long waiting times for assessment and conclusion. Most have got the same resources, many have incomplete multidisciplinary teams, and you've seen that many teams are struggling to diagnose other neurodevelopmental and coexisting conditions. Many teams are struggling to make recommendations about interventions and treatment. I would also say that many teams out there are doing a great job. So there are a lot of teams, of course, able to make nice guidance and able to do the things that we would hope that they could do. But across the board, it's really variable, and there's quite a lot of teams, as you can see from the numbers, that are not able to do that. Next, please. So, recommendations from implementation now, where there's capacity, start to gather pre-assessment information and use that to guide assessment. People clearly say that's useful. I really think that physical exams, and it should be done, of children who are presenting, because if you examine children from time to time, you do find things. And I'm sure colleagues would agree with that. We do need to fill the MDT gaps. And I say here where there's resource, but you could really make the case that there just needs to be the resource to do so, and there needs to be improved training and expertise in these teams to be able to make autism diagnoses on the one hand, but the other diagnoses that are needed and make the right recommendations. Capacity and funding is a challenge and won't be solved quickly. Next, please. Thanks very much to all of those teams who've responded, including some of the people around today. it's been NHS England have funded this, and we have already fed some of these results back to them at this sort of level. I'd be absolutely clear with people that we are not sharing individual service responses with anyone. I'm very happy to talk to take questions. I know, Charlotte, you've been looking carefully at those and might be grouping them, but happy to lead any discussion.
Perfect. Thank you very much, Jeremy. We've got a question from the beginning from Jane Hankins. Are you able to share the areas that engaged in the survey?
Am I able to do what with those areas?
To share the areas that engaged in the survey.
I'm not going to share the trusts. We've said we won't do that. I have evidence about geographical representation, and there's representation from across the UK on that. But we aren't going to say which teams did and didn't take part. Those teams might tell you, if you wanted to ask your own local team, whether they took part or not. And we have said to those teams that they will get an output from this for their response versus the sort of average response of teams across the UK, which I think will be hopefully useful for local service development.
Brilliant. Thanks, Jeremy. And the next question is, do we know the makeup of each team's workforce of the lack of capacity across medical, nursing and therapies and others? So this was at the beginning of your presentation when you were talking about capacity. Right.
Okay. So I guess maybe the MDT table, multidisciplinary team professionals table, gave you the answer to that. I think those data are pretty robust. I have to say, I'm confident in those data. We did the child development team survey that some of you also completed 10 years ago now, came up with very similar responses from the paediatric teams, although we didn't look at the mental health teams on that occasion.
Perfect, thank you. And then Jane Dunlop has said it's very interesting to see the confidence within CAMS with identifying learning disability. Maybe there's more access to psychology in their teams than the paediatric teams, with a question mark. Yeah. So what are your thoughts on that?
Absolutely right. I think they're right. You know, I work in, I'm a paediatrician working in a CAMS-based team. We do intellectual disability assessments of probably 90% of the young people we see. And where we don't do them is because we are absolutely confident that the young person doesn't have a learning disability. But I would also say it's not only about their learning disability, it's about their learning profile. So, you know, those of you who've seen lots of children will have identified, you know, verbal strengths in some, but a big gap between their verbal skills and their processing speed. And of course, when you think about their educational attainment and the support they need in the classroom, it's that 30-point gap between their verbal IQ of 120 and their processing speed that can be really helpful.
Yeah, brilliant, thank you. And then Raj has just said some of the gaps identified could be related to who may have answered the survey, e.g. for paediatricians may have answered that they referred to SLT for language disorder, even if SALT was a part of the paediatric team.
Yeah, so I get that, except the fact that, you know, let's just work this through. So people are being referred, they're then waiting 10 months for an assessment. We know that assessments then take a very long time. It then takes a long time to conclude. And then we're saying that after the conclusion and the formulation and creating the recommendations, one of those recommendations should be that they're referred to someone else for a developmental language disorder assessment or an anxiety assessment. I'm just thinking about families and young people's sort of progress with time, the support they need in a timely way, because, you know, all of you on the call just know how long what I just summarized takes. So if you're getting to the end of a process and then you need onward referral, that's a huge challenge, isn't it? Because you're talking about 2 to 3 years before you're getting the support you need in the services where things are taking the longest amount of time. Now, clearly in the services that are able to do things quicker, you might be talking about 3 to 4 months. So you've got variability, and dare I say it, I think that's inequality between services and potentially inequality within those services between people, which we didn't look at.
Brilliant, thank you. There's a bit of chat going on in the chat. Just Carol said that our paediatricians say it's not their role to diagnose learning disability, but Bernie Dawson in Hull has developed a model for Children's Neurodiversity Service in Hull, and is sharing that if anybody would also like to be involved in that. And then just scrolling up to some more of the questions from the beginning of the slide.
Can I just mention something on that though? I think one of the crucial things is to inform the diagnostic formulation and the recommendations package. It's really important to identify whether people do or don't have intellectual disability, whether they do or don't have developmental language disorder, DCD, etc. I'm just making the point that these assessments are not just about autism. It's not just saying, yes, this child, I'm afraid I work in a tertiary service and I do receive referrals where it says, we concluded this child didn't have autism. It then doesn't give another diagnostic formulation. And that's a real problem for families because they're coming away from a long wait and a long process, but not receiving a detailed formulation.
Okay, thanks, Jeremy. And then Leslie Platts said it's interesting to know age range often from Pediatrics is 0 to 5 and CAMS is 5+. This could link to different diagnosis and skills for these.
Yeah, I think that's right. It could do. We do have those data around the different teams and the different ages that are seen in each one. But of course, if we also know that if you're seeing a child at age 6, given that the average age of diagnosis in the UK is between 3 to 4, if you're seeing a child who's age 6, you're potentially still needing to identify their language disorder. And if you're in a CAMS team, you don't have enough speech and language therapists to do that. But I do take that point that there is there's some digging needed in relationship to the age ranges.
Thank you. And Lorraine Mulroney has said, if we had a core commissioning model, would that help? And Carol Sparing has also said clear commissioning model for neurodisability, not just ASD, would be fantastic.
Yeah, I wholeheartedly agree with you. One of the next stages of this research program that Ian's leading and I'm involved with is a further work package around working with individual trusts in the UK and potentially the commissioners locally to think about what's working well in certain trusts and what are barriers and facilitators to change and innovation. Now, it's possible, of course, that integrated commissioning will make a difference to this. It's possible that NHS England are also highly motivated. It's in the long-term plan to make changes to improve children's autism diagnostic services. So I think we could look at this at different levels. We could look at this at a commissioning level. We could look at this at a financial level and a funding level. We could look at this at multidisciplinary team expertise and training, and I'm afraid probably we need to look at all of those things, and we all know that that is not a quick fix.
Yeah, thanks, Jeremy. And Bernie Dawson said, have you considered the impact and requirements for sensory processing requirements?
Yes, so I haven't presented all the data to you today. I've probably presented about 2/3 of it and probably the things I thought you were going to be the most interested in. We do have data on that, so happy to present that at some point.
Brilliant, thank you. And just scrolling down the chat now. Yeah, diagnosis of LD is an issue across the agencies, but there is hesitation in using this label. And
there's hesitation. I think there's hesitation where people don't have the evidence. But of course, if you've done a cognitive assessment done by someone who feels they've got a good representative answer from the young person themselves, and it was representative of their skills, it's really important to say if someone's IQ is 50, especially if you thought it wasn't, and you thought they were within the average range.
And we've got a question about where and when will this be published?
When, as soon as possible. We're currently writing it. We've had to do the whole analysis again, of course, because of those 4 additional teams who are great that they came in. It's slowed us slightly with having to reanalyze everything. We're going to publish this in the way we are, CAMS teams and Pediatrics teams, but we're also going to try to publish this in terms of the characteristics of teams that are able to meet NICE guidance and those that say they're not, because of course I suspect we'll find out why people say they're unable to meet NICE guidance. Given how long publication takes, I can't say for certain that they will be out in 2021, but I sincerely hope so. Okay. Just to say, if there are people attached to regional British Academy of Childhood Disability or other meetings, and you wanted a summary presentation at regional meetings about this, we're happy to present about it.
Thank you. And Sylvia Jenkins has said that you said that children and young people presenting with more complex needs than 5 years ago. Why is this? The ability to identify issues better now, or children and young people are older, having waited for 2 years, so no early intervention, or is it something else?
So we have a complexity scale that we've devised locally that we embedded within this survey. So I have the yes/no responses to all of the individual points on complexity. And you can define complexity at multiple levels. Of course, you just said it in relationship to the complexity at a service level, a child level, a family level, a safeguarding, etc., etc. So I can't present those results today, but happy to in the future.
Thank you. And what percentage of teams have a pathway for diagnosis of PDA?
Off the top of my head, I'm sorry, I can't answer that one. About 20, I think it was about 20% of the paediatric teams said they were confident around PDA, and about 40% of the CAMS teams. It's on one of the slides, so you can look that up afterwards, but I think I've got that about right. So, PDA continues to be something that the tertiary services get a lot of referrals about, although fewer than 2 years ago.
Thanks, Jeremy. And yeah, Carol Spenning has just said our OT service is swamped with referrals for assessment. Only OT is in our community functional assessment service, no mental health OT.
Yeah, so I think this is really important, isn't it? That OTs have multiple roles. They have roles in relationship to autism assessment. They have roles in relationship to thinking about developmental coordination disorder. I showed you the numbers around the feeding, eating and drinking difficulties, where the OTs have an important role as well. So one of the challenges here is the number of professionals who are around with the right skills to address these multiple difficulties that individual children have, and try to prioritize what to address when. Now, we didn't ask people about whether they could prioritize, we just asked about people whether they could or couldn't do these things. I suppose they're saying, quite a lot of the teams are saying they can't do these things, and they ask someone else to do it. And I think it's those onward referral rates and the delays that causes that concerns me a little bit. I was asked at the NHS England workshop by someone saying, well, would people say they weren't commissioned to do these things? Well, of course, if they're the autism diagnostic and formulation teams, and they're where the autism expertise sits, if they're not commissioned to do these things, who then is? Who then is commissioned to do that additional work in a timely way with enough knowledge of autism to get through? So I think that's a challenge.
Thanks, Jeremy. Yeah, and Leslie Patz has said that lack of paediatric OT is a national concern. And we've got one more question is, can Jeremy give us an opinion on the need, desirability for a pathway for PDA? Does his service make this diagnosis?
I think I would prefer, so PDA is one of those topics that polarizes people's views, isn't it? I think now the PDA Association and others have moved to seeing PDA within an autism spectrum context. So I think that is very positive. I don't think it needs its own pathway. I think it needs considering as part of the autism spectrum pathway, but people need to feel confident with what they think PDA is, and how to put in place recommendations to support that, whatever they've put the PDA related difficulties down to. We often identify people's anxiety as a cause of their avoidance. We don't make many PDA diagnoses or PDA subdiagnoses in the team I work in, but we think very carefully about it and we formulate it in what we think is the most appropriate way and make recommendations out of that. So I think that's a better approach than a separate pathway.
And
I suppose I should say that's a personal view, of course, not representing the views of others.
Perfect, thanks, Jeremy. And Leslie Patz has said, should we look at integrating the skills of health and CAMHS into single service pathway?
So I think the work package 4 in the broader programme will look at that. My own view is, as a paediatrician working in a CAMHS-based team, is that it's really helpful that I work with paediatric trained occupational therapists and paediatric trained speech and language therapists in that mental health based team. So we're bringing a lot of paediatric expertise into a CAMHS-based service, which is effectively an integrated service. So, if we have a young person who the primary presentation has previously been a mental health condition, and now people are wondering about autism, they're seen by the child psychiatrist in the team, or they're seen by a consultant clinical psychologist in the team. And I might be more likely to see a child with a different profile that relates to my particular expertise. I think more integration would get rid of these gaps between paediatrics and CAMHS numbers. Paediatricians have got to get better at things like anxiety, and the mental health teams have got to get better at developmental language disorder and DCD, and so on.
Perfect, thank you. Yeah, and Siobhan has just said we're looking at this in Newham. Currently, CDS is up to 10, 11 years, and CAMHS comes in at 11 plus. Very fragmented pathway and very long wait lists, very long waits.
Yeah. So I guess that is the challenge. If you put the whole lot together and you don't increase the resource, you might create an even longer waiting list than you had for the two services individually. But I do, my hunch is that integration is part of the solution, but it's not the only solution, because you have to have the commissioning arrangements, the money to flow, and the buy-in from the trust or trusts, plural, potentially, of course, to do that.
Perfect, thank you, Jeremy. And so we have just 3 minutes left of the session. Does anybody have any final questions for Jeremy to pop in the chat, or please raise your hand?
I can see. Yes, I agree. Skilled workforce with transdisciplinary learning. Can I make a comment then, just Charlotte, at the end? First, as I said, some of you have completed this. Thanks so much for doing it, and you can see the value of the data. I would also just come back to this point that there are a lot of professionals out there doing a great job in teams, and there are a lot of professionals out there doing a great job in teams that aren't delivering what they want to. So a lot of clear open text responses with people saying, we want to be doing better, but we don't have the resources to do it. So there's a whole lot of skilled and motivated professionals out there. And of course, a survey like this doesn't do all of them justice, but it does show the gaps and some of the challenges for the future.
Perfect. Thank you very much, Jeremy. If anybody has any more questions, please feel free to raise your hand or pop them in the chat box. If not, you have a 10-minute break now, and so you'll be going into your second workshop at 12:30.
Thanks, everyone.